Good evening, ladies and gentlemen. Hearty welcome to the 30th session in our Learn from the Legends International Webinar Series in Neonatology, organized by IAP NeoChap and NNF Kerala. I am delighted to welcome Professor Haresh Kirpalani, Emeritus Professor at the University of Pennsylvania, USA, and McMaster University, Canada. Professor Kirpalani was born in India and educated at UK. He trained as a pediatrician in the UK at Newcastle upon Tyne and was a senior fellow in neonatology at the Hospital for Sick Children in Toronto, Ontario. With his rich experience, I'm sure he will enlighten the crowd this morning. A warm welcome to you, sir.
Thank you.
We have an eminent team of moderators also today. It's none other than Dr. P.K. Rajiv, Senior Consultant in Neonatology at Dubai, and Dr. Prashant Gowda, Consultant Neonatologist at Bangalore, and incidentally is the Secretary of NNF Karnataka chapter as well. Thank you, both of you, for joining the meeting. Now I hand over to the moderators. Kindly take over the proceedings from here on. You're muted.
Thank you, Ravi, for the nice introduction. And we go back in memory lane for almost maybe nearing 30 years when we started newborn intensive care in Kerala. And the first ventilated baby was in '93, somewhere in August. And with so many decades, we have progressed very well in all areas of healthcare and also in neonatal intensive care. So I think we should start the session. And Prashant, would you want to add on something to this?
I think, first of all, thank you NNF Kerala and IAP NeoChap for giving us an opportunity to moderate this session. Thank you, Dr. Manoj, Dr. Vishnu, Dr. Ravi sir, and the entire organizing team of NNF Kerala. So we are all privileged to participate in this session. And today's session is on blood transfusion and in premature babies. In our day-to-day practice, we do come across a lot of questions about the latest evidence. How what are those evidences which will change our perspective of our understanding in blood transfusion in premature babies? So I would request our professor to take over the session. Professor Haresh sir, over to you.
Many thanks to both of the moderators, Dr. Rajiv and Dr. Gowda. Look, I first of all want to start by thanking very sincerely the organizers of this meeting for the privilege of speaking to you. And that obviously includes everyone in Kerala, Manoj and Dr. Ravi. So let's see if the system allows me to share my slides. Can you first of all tell me that you see the slides? Is that
yes,
okay?
sir, you see the slides.
And you can hear me okay?
Yes, your voice is also perfect, sir. Everything is perfect.
Okay.
Please go ahead.
So the situation in India, as in the rest of the world, is not great right now. And I feel very sorry for everybody suffering under this yoke right now. I understand from the newspapers, it's a little bit inaccurate, I'm sure. They estimate that 1,000 doctors have died in India. It's a terrible situation and wish you all well. My topic is going to be blood transfusions for preterm infants. What is the evidence base? In the next 40 minutes, I hope to cover a few topics. First, I'd like to thank the Canadian Institute of Health Research and the US National Institute of Health for having given me funding to enable me to talk about these things. You've got to bear in mind that there's a conflict of interest. I am the PI of the top trial, so whatever I say, please take with a truckload of salt. And I'm going to start here with this introduction, which is, I want to put you in the mind frame of what we're going to discuss in about 40 minutes. I'm really going to ask a philosophical question. Why was neonatology so very slow, I've emphasized slow, at answering the question when to transfuse? And the clue that I'm offering you is that we just, as a community, we just love physiology, animal and observational studies. There's going to be a few evidence-based buzzwords and phrases, but I'm going to leave them largely unattended to and for you to pick up if you want. But these buzzwords include things like bias and surrogate outcomes. More concretely, the two major areas I'm going to cover are definitions of anemia, clinical burden and effects, and the risk-benefit ratio. And then I'll move to really the randomized trial data, and I'll discuss the top trial with its markers of internal validity. But it's very important to consider external validity. And because one of the moderators has asked me specifically, Dr. Rajiv wanted to hear a little bit more about neuroscopy. If we have time, I'll show you a few slides at the end on neuroscopy and my perspectives. So why are we confused about blood transfusions? It goes back basically to the dawn of intensive care in neonatology. This is data from Scandinavia in the 1970s, and I draw your attention to the first row. Here, the y-axis is hemoglobin in grams per deciliter, and the x-axis is postnatal age in months. And you can see between the 5th and 95th centile for hemoglobin, there's a vast difference for 1,000 to 1,500 gram birth weight infants. Such data led the authors to say there are rapid developmental changes, and these prevent developing clear-cut criteria. So clinical practices vary widely, they predict. Now this was in the 1970s through to 1981. So obviously we must be doing much better now, right? Well, unfortunately, you all know the answer is no. This is data from a very large survey in 2012 by Ursula Guillaume, where she asked over 1,000 neonatologists in several countries, mainly in well-developed countries, at which hemoglobin would they transfuse an infant born less than 1,000 grams birth weight, on the x-axis in varying degrees of respiratory support, and the y-axis in hemoglobin's grams per deciliter. The black bars in the first week going down towards the 4th week. And here you can see that the means and interquartile ranges, the median, I should say, and interquartile ranges vary dramatically. So there is no agreement. Why is that? Well, when a neonatologist approaches an infant and considers whether she should transfuse that infant, a range of things go through her mind. There's a risk-benefit balance, and higher hemoglobins are said to improve oxygen transport, cardiac output, weight gain, apnea. But at the same time, they may increase infections, donor-related as well, iron stores, necrotizing enterocolitis. Recently, there's been a lot of talk about death rates, and there's a bit of complications from mold blood. We'll go through a couple of the more important of these. First is the issue of cerebral oxygen saturation. Now, there's loads of data on this, and it's mainly observational data. This is one of those that first started this band of reasoning, and it comes from Holland. What you can see, I want you to look at this graph, the one most on the left of your screen, which is regional cerebral oxygen saturation. This is not randomized, they're triplets of values. And this is when the clinician decided to transfuse, either for hemoglobin less than 97 grams per liter, or 97 to 113 or 113. And each of them shows a characteristic pattern. There's the value before, the value during, and the value after the transfusion. And you can see there's a jump upwards. Obviously, to some people, this reads that this must be better because there's a jump upwards in oxygen saturation in the brain. I'm going to argue that this is a surrogate outcome, not tied to any meaningful clinically relevant outcome, and we do not yet know the relevance. I could show you exactly the same graphs for cardiac output, but we don't have times to go through that. My point is that yes, physiology can give us some insight, it can raise a question, but we have to answer that question on the basis of clinically relevant outcomes, not physiological surrogate outcomes. At the same time, moving towards the downside, there's the issue of transfusion safety. Now, we're a lot better than we were. This is data from Naomi Lubin in New York and Washington, at the National Children's Hospital. From 1983 on the x-axis through to 2001, we've seen a huge change. Obviously, the epidemic of HIV struck us like lightning. I remember being in Sick Kids in Toronto, wondering why a child I was looking at had very severe symptoms that I couldn't quite understand. And obviously, this was a new phenomenon. So I think what we have is a situation that's changed with HIV that's been now improved by better screening. Manoj, I've had a warning that my computer will restart in 5 minutes. It seems I can't do anything about it, but I'm just going to carry on. And if need be, I'll log back on to my laptop.
No issues, sir. If there is a technical hitch, we can always wait for you till it gets okay. Please carry on, sir.
Okay. So this goes on, and you can see that by 2001, after we've got much better screening, there's been a rapid drop. So from rates of a risk of infection per unit transfused from 1 in 100 down to 1/10 million. And the same for hepatitis B and C. Obviously, this is a huge improvement, but I don't need to tell you in a year of pandemic that there may be other issues that go on. The next issue is death. This was a very important study out of Brazil, showing in a very large database that the cumulative hazard it seems that my mouse has been disabled, so you can't, there it is. I hate these technical problems with computers and Zoom, but never mind. There's a cumulative hazard on the y-axis that goes upwards. The Brazilian database looked at the cumulative death rate from babies less than 1,500 grams birth weight who are in hospital up to 300 days, and they compared non-transfused to transfused infants. And you can see there's a major difference. Is this relevant? Obviously, it's a bit concerning, but I think this group understands that this is an association. And we're reminded of data from Bill Silverman, the founding father, I think, of evidence-based neonatology. And for the young people in the audience, this website at the top has his book on retinopathy, and I strongly recommend everyone read it or reread it. In there, he shows this graph of retrolental fibroplasia, now known as retinopathy of prematurity, with the x-axis showing from the years 1938 through to the 1950s, and the solid black bar is retrolental fibroplasia. You can see, however, that rates of oxygen and iron rising at almost exactly the same trajectory. And early on, people imputed ROP to oxygen and not to vitamins and iron and not to oxygen. So we've learned a lot about associations, but we still seem to fall into the same trap. This is the data in overviews for transfusions and necrotizing enterocolitis. On the left-hand side, what you see is the data from cumulative analysis for observational studies for NEC. Now, there's a lot of babies here, 12,000. It's very easy to build up a retrospective look at your databases. I'll point out that the diamond favors a restrictive pattern. In other words, not transfusing babies appears to benefit in lowering necrotizing enterocolitis. I'll also say right off the cuff that an odds ratio of 7.5 is implausibly high. On the other hand, we have a situation with 4 studies that are randomized and less than 600 babies. The diamond crosses over, but now you see the axes are reversed. Now we find that that favors a liberal transfusion. So what is the truth here? This is a very important study that I recommend to this audience, which is in all studies comparing the results of human trials and animal physiology and physiology trials. I don't
Kindly bear with us for a technical hitch. Professor Haresh Kirpalani will be back very soon. In the meantime, would the moderators want to discuss something regarding this until the time Professor Haresh Kirpalani is back? Please unmute.
Dr. Haresh, can you hear me?
Okay, he has come back.
Yes.
Please unmute, sir.
Okay.
Can you hear me?
Yes. Yes, sir.
I sincerely apologize to the audience. Computers have a mind of their own. They're just wonderful for us, but they have a mind. Let me now again get my slides up. Again, can you see my slides?
Yes, sir, we can see you. See your voice is also okay.
Okay. So now let me go back to where I was. I'm glad that I warned you that this may happen. So we were at this slide. And I think what I was explaining to you was that the slide displays a paper that's profoundly important in my view and overlooked. It's for all adult and other studies. I'm not going to go through the details. The point that I will say is that we now have in the neonatal population similar types of data. And I'll refer you to the caffeine study, where animal results were profoundly different in their effects from those in babies, and to the sustained inflation trial, which again is very, very different. I am not dumping on animal studies or physiology studies. They're essential. The message that I'm trying to convey is that for most questions of therapy, randomized trials must trump observational data. I think nowadays we can again use the word trump. The next thing I'm going to say is at least one large and valid randomized trial is necessary. With that, I'm going to move to the second part of the talk, which is to say, in the light of this, how do we know what triggers to use for hemoglobin? And what I'm going to say is that actually we're in a bit of a problem, because until very recently, if you look at the Cochrane, this is the only data there is for more than short-term outcomes. And actually, while there were two studies that informed us on hemoglobin cutoffs for transfusion, only one of those two studies, the PINT study from Canada, looked at long-term outcomes at 2 years. The Iowa study was a much smaller study, and it did show longer-term outcomes. The problem was it looked at 7-year outcomes, I forget the exact age, but around there, using a surrogate outcome of MRI. But the big Achilles heel of that study was that it had an attrition bias of over 50%. So it was impossible really to make any meaningful conclusions, in my view, in that study. So reverting to the slide, this is the data that we have that we think is reliable up to very recently. And in a secondary analysis, this wasn't the primary outcome of the PINT study. In a secondary analysis, one standard deviation appeared in Bailey assessment at 2 years of age in survivors, appeared to show benefit. However, the 95% of the confidence interval touches equivalence. So there's a problem. And actually, we had a real issue in deciding what to do. That is why I think we were very fortunate, and I again thank the NIH for their funding of the top trial for this question. And we were very fortunate to be able to publish that at the end of last year. This is the PICOT question of the top trial. In a population less than 1,000 grams, does the intervention that's randomized to a high hemoglobin threshold versus a low hemoglobin threshold improve the outcomes of death or neurodisability at a time frame of 22 to 26 months? This was an unblinded, pragmatic, randomized trial. I want to stress that the maneuver itself was unblinded because we couldn't ethically withhold that information from clinicians. But very importantly, we made sure that the primary outcome was ascertained in a blinded manner by follow-up physicians who were unaware of the allocation. It was stratified by center and birth weight. There were 2 hemoglobin threshold algorithms. No blood sampling was mandated, and the intervention was continued to 36 weeks. In a little bit more detail than was possible in the PICOT, this is the inclusion criterion. Infants were 22 to 29 weeks and less than 1,000 grams birth weight. We wanted to be sure that we applied the algorithm early, so it was less than 48 hours, and no blood transfusions in the first 6 hours unless emergent had been allowed. We excluded infants who were non-viable in the physicians' minds. We obviously obtained consent, and we excluded infants with congenital heart disease, in utero fetal transfusion, and importantly, anybody who either was intended to get EPO or had already got EPO. This is the transfusion algorithm, and if you've read the Pint paper, you'll see it's very similar. On the left-hand side is hemoglobin going down in grams per deciliter by week of postnatal age. Along the top, we asked, is the baby receiving respiratory support? If yes, the baby was randomized into high and low. If no, again, into high and low. So the putative anchors for hemoglobin was a high of 13 grams per deciliters versus 7 grams per deciliter. I've said that the primary outcome was by a blinded assessor, and it was death or neurodevelopmental impairment in a standardized format using a Bailey assessment for cognitive at 1 standard deviation below the mean, or cerebral palsy using GM-FCS, or blindness or hearing deficits. We had pre-calculated on standard alpha and beta that we needed 1800 for a meaningful clinical difference. And essentially, we managed to recruit those, and we had 86% survival to discharge. We duly followed these up, and you can see that we obtained 93% follow-up rate for neurodevelopmental impairment or death. So I think we've got some valid information. For the baseline characteristics, we achieved reasonable equality between the high hemoglobin and the low hemoglobin, a slight imbalance in female gender, for which we had a priori decided to adjust for. Corticosteroids, you can see high as you'd expect in this day and age. We did manage to randomize early, and the initial hemoglobin was good. I'll draw your attention to one issue, so that the maternal education higher than high school in this US-based study was not as high as it would have been in the Pint study, for instance, where the majority of babies were in the Canadian study. So did we manage to achieve our separation of arms? And here is a graph showing that we did. This is not a result. This is really a check to see, did the study perform as it was intended to do? And on the x-axis, it goes from day 0 of life through to week 11. And on the y-axis is the hemoglobin in grams per deciliter between arms. Confusingly, I'm sorry, but the blue here is the high transfusion arm, and the red is the low transfusion arm. And you can see that we achieved a statistically significant separation between arms, which was achieved very early on and was of the order of 2 grams per deciliter and maintained right through to hospital discharge or 36 weeks. This is the primary outcome. And as you can see, the rates of death or NDI in survivors at 22 to 26 months was exactly equivalent. And if we broke out the components of the primary outcome into the main subcomponents, again, you'll see that there's no difference, whether for death or for neurodevelopmental impairment. Naturally, we looked at a number of selected hospital outcomes. And as you can see again, I think, whether you're looking for severe abnormalities on head ultrasound, the neck, you'll recall the controversy about neck, the controversy about apnea, or indeed about retinopathy or growth, no difference. Nor was there any difference for bronchopulmonary dysplasia at 36 weeks, using by and large the modified definition that was first proposed by the Case Western group. This is the outcomes in numbers of transfusions, etc. Now, obviously, number of transfusions by design will be different. The high group had a statistically more rate of transfusions. But what's important, I think, in this slide is that if you ask the question, did the babies ever get transfused? Only 3 babies avoided transfusion in the high arm, whereas 12 babies avoided transfusion in the low arm, which is statistically significantly different. Now, we had allowed the physicians, if the baby was, for example, in a bleeding situation, or if the baby was undergoing a perforation or was going to surgery, we allowed them a couple of opportunities to put the algorithm on hold while they did what they needed to do and then came back. So that was not a violation of the transfusion. But on top of that, we tracked every transfusion and ensured whether we could see that the baby was following a protocol compliant transfusion or not. And as you'd expect, we had an imbalance. So there were more protocol compliant transfusions in the high arm than the low. And if you looked at frank violations, it was 8% in the low arm versus 0.8%. Now, that's not formally statistically significant, but it's a marker that we don't avoid discussing. Obviously, clinicians have a bias, it seems. They think that their hemoglobin value is low and they want to transfuse. I would say it's still a relatively low number in this large transfusion cohort. And so I think internally, we have not violated validity. So I've explained this in some depth because I think that it's something we need to share. Now, I want to talk about not internal validity, but external validity. It's very important, if you remember what I showed you, to have, if you can, some replication. And fortunately, the German group, led by Axel Franz, recently reported a very similar trial. Now, it was smaller. It was about half the size of the top trial, but it showed no statistical significance in the two groups. And the ranges of hemoglobins were very similar. There's another way of asking about external validity here. This is a very nice meta-analysis done by co-workers at Charité, led by Professor Dahm. And Professor Dahm here asked the question of early erythropoietin, which achieves the same hemoglobin elevation goal. Now, you'll see in their plot up here that their diamond for the long-term outcome at 2 years appears to favor EPO. But I'm going to point you out to the fact that it relies heavily on this trial. This is a situation very similar to the one I pointed to you in the observational study about necrotizing enterocolitis and blood transfusions, because what you can see is that the odds ratio is astonishingly high. The odds ratio here is 0.3 favoring EPO. When you see this in a biological system, and moreover in a clinically complex system, you've got to ask,
can that be true? Is that really true? There are very few things that we do in medicine that have such a punch. So you need to ask about that. Now, fortunately, we can ask an extra question. This is the large single trial, because I should have said, going back, I should have said that the Song 2016 trial was unblinded, which Professor Dahm points out to me. Fortunately, there's been another trial, and this was reported by Professor Jewell about a year and a half ago. And the primary outcome was death or severe NDI, almost exactly the same as the primary outcome of the top trial. And there was no difference, as you can see on the bars at the top. Moreover, a secondary analysis passing out the different components also showed no difference. So despite the technical hitches, I think I've shown in about 35 minutes what I had wanted to show. So Dr. Rajiv asked me to address the issue of neuroscopy in a bit more detail. So I've added in a couple of slides which we can go through very quickly. And this is the way that I asked, where do we go after the top trial? What's next? And the first thing I'm going to mention is blood banking concerns. So electron microscopy of fresh harvested red cells is beautiful. Doesn't that image look amazingly pretty? If you store the red cells, they look not so pretty. Now, you may have noticed a sleight of my hand, because this is a black and white picture, not a nice color picture. It was the best one I could find to illustrate the schistosomes and all of the variety of shapes that stored red blood cells take. Fortunately, we know from a randomized trial that was launched out of Ottawa and reported in 2012 that there is no difference between the rates of the composite primary outcome of NEC, IVH, retinopathy, BPD, or death in preterms when the comparison was between standard red blood cells whose age went up to about a month of post-harvesting to fresh red blood cells whose age was less than 10 days. This is a very important study from the point of view of the economics, as any country or unit which is strapped for resources, which basically comes down to every unit, because the cost of getting fresh red blood cells far outweighs the use of stored red blood cells. But what we don't know enough about is exactly how to store the blood. So if anybody out there is looking for a project, that's one of the next things that needs to be tackled in this area, in my view. But the issue that Dr. Rajiv wanted me to talk about was neuroscopy. In 3 slides, I'm going to give you my take. So an old fellow of mine, Chad Anderson in Adelaide, has thought very hard about the physiological parameters that require consideration in individualizing blood transfusion. And that's where we need to go. It's very complex. You need to consider also cardiac output and oxygen extraction using preferably neuroscopy. Now, the problem is that this is a surrogate outcome, as I said before. Only one group that I know of has actually taken up the challenge of doing a randomized trial. And this is a very important trial that was done out of Copenhagen. These workers, led by Heitel Sorensen, reported a few years ago. Now, it's a small study, that's the problem. Only 166 infants. What they did was to randomize infants to either receive an unblinded screen for gyroscopy. So here, the clinicians could see the screen. The other half was blinded. The screen was totally blinded, so they couldn't see. They defined the burden of bad oxygenation as being either hyper, shown here, or hypo. So less than 55% on cerebral oxygen saturation or greater than 85%. And they convincingly showed that they could get a benefit in terms of the amount of time spent by gyroscopy in these bad zones was statistically highly significantly better than in the blinded group. The problem was that there was no difference in all-cause mortality or in brain injury. Now, to their credit, they recognize that that is unpowered, and they are in the middle of doing a large pan-European trial. So you should stay in tune for that. Until we know that, I don't believe that the surrogate outcome of cerebral hypoxia or hyperoxia confers any benefit. So for now, I'll close with this slide. I believe that in the top trial, an approximate 2 grams per deciliter difference made no significant differences in the primary outcome or in the important hospital outcomes. So I believe it is safe to stay within the ranges of the top algorithm to transfuse preterms. I thank you all for your attention, and I sincerely apologize about the technical issues that made this perhaps a little bit more difficult to follow, but I couldn't do anything about it. Thank you. Hello?
May I request the moderators to kindly take over?
Dr. Haresh, thank you for that brilliant presentation. I have a few questions which was troubling me after going through this topic. In the area of NEC, there was one study which was giving a real pointer that this transfusions led to NEC. There was a second study which said that if you stopped feeding for 48 hours, this effects of transfusion-related so-called NEC was obviated. So these 2 points, I would like you to throw us some light on this area of NEC and transfusion versus stopping the feeding for 48 hours and things were much clinically better on that area.
Thank you very much. So the first thing I would say is that I think the meta-analysis that John Sapanchik and I showed, and I showed that in the early part, shows very clearly that when you compare observational studies to the data from randomized trials, you get a 100% difference, an polar and opposite difference in the estimation of risks. And that sort of comparison between observational data and randomized data holds true when you look at it for adult studies. The first real observation of this was made by an epidemiologist called Professor Ioannidis. So I recommend you look at that. The second thing I'd say is that the observational data, the best study was performed by Ravi Patel. And Ravi's data definitely was an improvement on the prior data because it was prospective. And that group defined that a cutoff less than 6.5 grams per deciliter could be pivotal. And they did show that there was an increased risk less than 6.5. Now, he did that study after we had decided our hemoglobin cutoff ranges, but you'll notice that our hemoglobin cutoff ranges, just as pint was above 6.5 at 7. And I decided that I did not want to broaden the limits between low and high, because that would have been unethical, because I thought that this was a problem. So that's one answer to the question that you've raised. The other issue about whether to transfuse or not revolves around the whole question of whether you believe it's a real phenomenon. I don't believe it's a real phenomenon if you stay within the ranges of the top algorithm. For years, I was transfusing infants and feeding them. My group at CHOP, by and large, agreed with what I was proposing, and most of my colleagues would not hold transfusion. No one, to my knowledge, has done a randomized trial assessing the withholding or not of feeds during transfusion.
That is a good conclusion.
Sorry, I can't hear you.
So please unmute yourself.
Yeah. The second question I want to ask.
Sir, can you kindly unmute yourself?
I think it's unmuted, isn't it?
Yes.
Yeah. Please go on. Please go on.
Can you hear me?
Now I can.
Yeah. So, Dr. Haresh, the second area which I already mentioned to you last time, there was a study which showed that many specialists worldwide are hesitant to go below 7 to 8 grams in transfusing. It was a questionnaire sent to most centers in Canada, that we are a little bit, by design or by experience, we feel a little bit overcautious to go below 8 grams in transfusing. But there's a flip side to the story. With Dr. Bell, with whom I worked in Iowa, that subgroup analysis which I mentioned yesterday of the kids who did badly in the range of 7 grams hemoglobin, who had more hemorrhage and neurodevelopmental outcome in the subgroup analysis, his physiological explanation was, if you tax a baby's hemodynamic system with anemia, there'll be a rebound perfusion of the brain in those pressure passive circulation areas, leading to more hemorrhage. So I wanted this area was really a very interesting pathophysiological relationship. I want to throw light on this.
So first of all, what I just point people's attention to is Gautam Suresh. I think that's Gautam Suresh, points me and the group to an RCT on withholding feeds. If I'm not familiar with that trial, but if I'm guessing, it's a relatively small trial. But I commend people testing what you say, Dr. Rajiv, is an important issue, which is a clinician's feelings or observations to a formal randomized trial. So I think that that's important. Regarding the subgroup of the Iowa trial, again, I must draw attention to the fact that the long-term outcome of that trial had over 50% attrition bias. So it's rather difficult to make too many firm conclusions on the basis of that trial. On the short-term outcomes, it's likely also not to be able to place too much emphasis. In any case, I'd submit that right now, we don't have enough data to be 100%, but perhaps we can get some other questions or whatever.
Prashanti, please take over from the questions.
Yeah, first of all, thank you, Professor Haresh, for your wonderful presentation. We have a list of questions. I'll try to cover up as quickly as possible. The first question question is about the quality of blood what we use for the transfusion. Less than 3 days or less than 72 hours, potassium level or pH of it should be more than 7.2. This is the guidelines what we have. Maybe does this quality of blood parameters holds good before we transfuse to the baby?
So, as I indicated, we know relatively little about how the blood bank should handle blood and give us blood for transfusion. We have the data from the Canadian trial that I showed you in the last few slides that I had inserted, which definitely shows, to my mind, that the issue of fresh blood versus, quotes, old blood up to a age of about a month of age, as long as it's stored by criterion held by the blood bank associations, is adequate. That appears not to show any difference. As regards pH and all of those, again, that falls within the sort of range, as I'm familiar with, that most authorities recommend. Beyond that, there's been some data from Canadian observational studies that if you irradiate blood prior to transfusion, that you may cut down the issue of graft versus host disease. But I would point out that that's a very, very low rate in the newborn population. And so I think it's very unlikely that that's going to be a major issue, but some countries have indeed adopted irradiation. Other countries, rather than irradiate, use other techniques to immobilize or trap white cells. Other than that, there's relatively little data. There is a new study being launched out of Australia to test different blood banking possibilities, but that's, again, at an early phase. So can you hear me, Manoj?
Yes, I can hear you. I think the connectivity issue is from his side only.
No,
yeah.
Can you hear me now?
It's still dropping in and out, but I think the question essentially is volume of blood to transfuse.
Correct.
So the volume of blood varies quite a bit between different units. You're quite right. And some units recommend 10, some say 15, some say 20. So we standardized at 15 for our study. There's very little data that can really compare between volumes. So I guess the theoretical risks, and that's, I think, where we can place our emphasis, because it's mainly observational. The theoretical risks boil down to a syndrome that is sort of can be labeled as transfusion-associated cardiac output compromise, or TACO, rather like TRALI, which is transfusion-associated lung injury. I don't think I've ever seen that, that I've recognized, but I agree that most of us are certainly not checking pre-transfusion cardiac outputs and transfusion post-cardiac outputs measures in a formal way. So I may have missed it, but I've not recognized infants that have been in frank cardiac failure, unless they had a prior existing cardiomyopathy or perhaps were on propranolol or something like that. And in those situations, that may well occur. And if that's at conjecture, you may well want to consider the use of something like frusemide alongside. But there's actually very little data, to my mind, that shows any benefit for giving frusemide halfway along a transfusion. I think so long as you're giving the volume of red cells relatively slowly, I don't think it particularly matters. Those babies who have bronchopulmonary dysplasia, I think probably end up in most people's hands having a little bit of extra frusemide. Again, that's not a practice that I necessarily endorse, but it's certainly a practice that I may have done. I don't think that has been actually assessed very well. It sort of reminds me to talk about the issue of trally a little bit, of lung injury, because that's certainly a major worry. When you look at the observational data out of the British SHOT trial, for instance, which was a large blood bank study that was performed where they did in fact evaluate a lot of outcomes in both adults, children, and babies following transfusion. They suggested that an analysis showed a higher rate of trally in adults. And that was then confirmed out of a study in the US. But the data for infants is relatively less. And I must say that the definitions of trally that are adopted don't easily apply to the ventilated newborn. When people have tried to modify those definitions, that hasn't been very helpful. And all I can say is in the top trial, we did not notice an excess of either bronchopulmonary dysplasia or if we then asked, were babies on ventilators for longer, or did it delay the age at which babies were weaned off caffeine by the clinicians? We didn't seem to see any difference. So I'm not sure right now just how important trally is for consideration in newborns.
Okay. Another question on, because when a newborn comes on blood transfusion, the common things what we discuss is PVL, NEC, BPD, and the neurocognitive disabilities which is seen in future. So regarding this, there's one question: the link of hemoglobin percentage and blood transfusion with the risk of PVL changes. So what is your take on the percentage of hemoglobin at which you would like to transfuse, which reduces the risk of PVL as well?
Well, I think that that's a very reasonable question. We combined severe IVH and meaning including intraparenchymal echo densities and PVL. What we used in the operating rules were very, very similar to those that had first been, I think, very clearly demonstrated by Barbara Schmidt's types of studies using the indomethacin trials and the CAP trial as a vehicle, which is the latest ultrasound that you have, that the clinician has. So what that means is that if you continue that up to a possible 36 weeks ultrasound, most of them stop around about 30 to 32 weeks. Most of them thereby involve the evolution of IVH through to intraparenchymal ecodensity, through to PVL. So despite the observational data suggesting that more transfusions reduces severe IVH and PVL, we didn't show any signal, again, within the ranges of the algorithm. It reminds me to say that going lower below that cutoff range may get you into a zone of ischemic threshold. And that's the reason why I think you could get into trouble, but it's speculation. But I didn't want to go there for the top trial because I think some of those cases of so-called transfusion-associated NEC or ischemic PVL are in reality a situation rather like the coronary artery situation in adults. And I'll explain what I mean very briefly. And probably we've come to the end of our time for questioning it then. But what I mean is that if you get down below a certain barrier, you then induce a subclinical ischemia, which if you then transfuse on top of, you induce a hyperperfusion ischemic reperfusion issue. And I think that's what might happen in both the gut and the brain if you go below those recommended levels. If you remember, there was a fashion for withholding transfusions. As people became wary because of the HIV epidemic that swept through, people stopped transfusing. And actually, it was at that point that I was impelled to do the randomized trial to see what should be the cutoff. And I think people went below a certain barrier. If you go below that, I think you develop local ischemia, and then you transfuse finally, and you get a reperfusion injury. But within the ranges that I've said that we held the top algorithm, I don't think we saw that. In any case, I fear that Manoj, we've probably come to the end of the questioning, have we?
Manoj?
Yeah. Moderators, please carry on. Please unmute. Raju sir, unmute.
MR spectroscope.
Yes, Raju sir.
Can you hear me? Yeah, can you hear me?
Yes, yes, yes.
MR spectroscopy has come in a big way to be in the bedside in certain centers in US. Won't that be a good start to define your transfusion threshold, especially with pertaining to the IVH and the PVL, which if you go below a certain gray area, will lead to ischemia and reperfusion injury. Will MR spectroscopy help us in this area?
Let me say honestly, I've never used a mass spectrograph at the bedside particularly. If you're talking about, are you talking about neuroscopy?
No, MR spectroscopy, energy metabolism.
Yeah, okay, right, okay. To be quite clear for me, so if neuroscopy is what we're talking about with the use of evaluation of cerebral oxygen saturation, that I think I have some understanding of. I've never used it personally, But I think, again, for all new technologies, it's crucial to actually test them at the bedside in a randomized manner. So, as I've said, there's a huge proliferation of new technology data using spectroscopy that will need careful sifting through. The Copenhagen paper, I recommend that you use that as a starting point. It was in BMJ. The author was Heitel Sorensen. I forget the first name, but that was a randomized trial which appears to show no benefit in the use at the bedside for the primary outcome of either death or severe IVH. Therefore, I think that that trial in its new form, as it is in a much larger manner, powered for that clinical outcome, I think that will give us the answer whether it helps or not. It would be wonderful if it does, but until that data is provided, I think a healthy degree of skepticism is required.
Thank you very much. Thank you.
Sir, one last question. There are many questions. I think the time is up. But one thing is there any other marker apart from hemoglobin which would help us or which would guide us in terms of deciding on the blood transfusion? Because we have spoken a lot about hemoglobin percentage cutoff and the things like that. So is there anything which can you throw a little bit light on us on that particular aspect, sir?
Well, people have looked very hard for other markers and individualized markers. I mean, the data goes back really, I think, to the most important ones were the ones being tested by a group of workers in Glasgow, where these workers looked at taking blood from a baby and testing how much does that blood have available oxygen, how much does it liberate. The workers' names were, I forget their first names. One was Barbara Holland, but the other one was Professor Wardup. Wardup and Holland. And they tried very hard to demonstrate that this would be a better way of individualizing an infant. And it takes into account the whole notions of the differences between hemoglobin F and hemoglobin A. But unfortunately, it didn't work out. The diagram that I showed you, very complex from Adelaide, incorporates an individualization using a triangulation technique, really, of this notion of available oxygen in the notion of combining cardiac output measures and what Dr. Rajiv is so enthusiastic about, neuroscopy. That's really the best bet we've got to go on. The Dresden group, led by Mario Rudiger, looked at various other elements, but actually we don't really have anything else that I'm aware of. Intrinsic EPO has been looked at. That's not particularly helpful as far as I understand it. So at the moment, we're really left with a sensible approach within the guidelines of the top algorithm. This is my contention.
Sir, before we close, a lot of viewers who practice in periphery, one final, when we are transfusing blood, two things. What is your take on blood transfusion? You already told earlier they would withhold the blood transfusion. So if if the baby needs blood transfusion, say at hemoglobin of 10 or 8, should we transfuse one? And what are the common complications, immediate complications and the late complications, which you would suggest to look upon for the practicing neonatologist? Suppose if you're giving a repeated blood transfusion, what are the things which you would suggest we need to look upon? The common ones, which will help the viewers over here.
Okay. So this is really asking the whole talk again. What I would emphasize, let me emphasize one thing. Staying within the range of these top algorithms neither improves the outcome nor does it increase any risks. So if it's a fairly broad algorithm, I think you can stay within the algorithm if the baby is not actively bleeding. The other main thing that clinicians start to get very worried about and very wobbly about is if a baby is requiring a lot of oxygen. However, we showed no particular benefit for usage of ventilators or anything like that by giving a more liberal hemoglobin transfusion. So I suggest that you consider this the very, very last thing to do, to just add another transfusion at 10 grams. Finally, I'm sure if you're practicing in a place like mine, you will have colleagues who are anesthetists, who are surgeons, who will say, I am not going to operate. I am not going to take this baby to the OR. Yeah. In those circumstances, I have some sympathy. And I think that I would say to them, well, look, you know, there's very little data about this in surgery. But when I'm not holding the knife, and, you know, I think a lot of us in neonatal intensive care are failed surgeons. I did my FRCS part 1 because I didn't want to say I left surgery because I failed an exam. But I passed the exam and then I never practiced as a surgeon. I went into NICU for totally different reasons. I didn't want to be perceived as a failure. But when you're holding the knife, it's a very different situation. I can accept that a surgeon or an anesthetist says that. And I would, in most instances, agree. There are some policies like cardiac surgery in babies that people say they have to have fresh blood. There is no data that proves this. Even in the adult coronary care units, coronary care surgeons are beginning to question that. So if I had only a little time at the bedside, I would not necessarily get into an argument with my surgeon and my anesthetist. I recognize that in that situation, it's acceptable to give a transfusion that is known to be biologically passed through the recommendations of the biological blood bank system. I hope that I've sufficiently convinced people that they should stay largely within the top algorithm ranges. I thank you for your attention.
Thank you, sir. We are glad that you are a neonatologist and you work on that. If you would have gone into surgery, we have missed you big time. Thank you, sir. Over to Manoj. Dr. Manoj.
Yeah, well, ladies and gentlemen, Learn from the Legends is completing an year of academic feast in June. And we are fortunate to have 3 great talks in June. The first one we just now heard. We are so fortunate to have Professor Haresh Kirpalani with us. Thank you so much, sir, once again for caring to spare your time and be with us today. It was a true honor. I do really mean it. And we are also fortunate to have two of the great people, Dr. Rajiv and Dr. Prashant, to moderate this session. Before I request my colleague, Dr. Nelbijot Matthew, Secretary of NNF Kerala, to propose a vote of thanks, we have, I have 2 requests. One, we have Dr. Naveen Bajaj. He is the president of IAP NeoChap. I would request him to speak a few words. Please be brief, and then after that, also I would let me welcome you all to an academic feast during our special anniversary webinar scheduled on 17 June. We started on 19 June, now 17 June, we are holding our special anniversary webinar at a different time. The timing is different because we had 2 legends that day, Professor Ola Sockstead and Professor Richard Pollen. So like we start half an hour early at 7 p.m. Please do join us on 17. Now over to Dr. Naveen Bajaj.
Yeah, good evening. Good evening, everyone. Good evening, Dr. Haresh, Dr. Rajiv, and Dr. Prashant. It's our honor to have you all on the dais for this webinar, sir. And as Manoj said, we are completing nearly 1 year of this Learn from Legend. The idea was to have the speaker who have done the original research in that particular subject, and then and we have the opportunity to listen to them directly, and accordingly we can change, modify our practices here also. And I am very thankful and honored and privileged to say that it has been very well appreciated by one and all, not only in India but across the other countries also. Thank you, Manoj, for coordinating this great effort from the chapter and the local state branch.
Thank you. It's a team, it's a team effort. We are all there in together. It's a team effort.
And yeah, we were on another day, we were discussing that whether we should be continuing this or not. Probably, Manoj, I think looking at the enthusiasm of faculty as well as the attendees who are attending the sessions, we should be continuing maybe in the same frequency of once a month or so. And we would like to have teachers, professors like Dr. Haresh again after a few months on this dais.
I was just speaking to Professor Haresh previously, yesterday and today, like God willing, if we are fortunate to have a physical conference next year, so probably we should have him and Madam with us for the conference.
Yeah, we will have lunch or dinner with him if we can plan a physical conference.
Yeah.
So, not taking too much time, I'll just like to thank all the faculties who has contributed, all the speakers, international speakers who have contributed to this platform in last 1 year, as well as the local organizer, Manoj and his team, Dr. George and Dr. Vishnu and Dr. Ravi, for taking so much of efforts. Thank you, Manoj. Over to you and to Dr.
Okay, so we are already late. I should apologize to Professor for, we kept you waiting. And then Dr. Rajiv, he's also a very busy neonatologist, Dubai, Dr. Prashant. Anyway, thank you, all of you. Now, may officially, let's have the official vote of thanks. May I request Dr. Nelby George Matthew to propose a vote of thanks. After that, we'll close the session. Nelby.
Thank you, sir, and good evening, all. It's a great pleasure to be part of this team, and now to say vote of thanks. It's my honor to thank our legend, Professor Haresh M. Kirpalani, for the enlightening talk on the newer evidence of blood transfusion in preterm babies. An excellent session, sir. Thank you, sir. And next, I would like to thank the moderators, our senior neonatologist, Dr. P.K. Rajiv from Dubai and Dr. Prashant Gowda from Bangalore. I would like to thank our core team behind this. It has been conducted so meticulously. Thank you, Manoj sir and the whole team. Last but not least, I would like to thank all the attendees from approximately 65 countries all over the world. Thank you all once again till we meet again for the next session, which is so special to us, our anniversary session by two of the legends in the field, Professor Ola on delivery room management and Professor Richard Pauline on neonatal hypoglycemia on 17th of June, 7 p.m. Indian Standard Time. Till that time, take care and stay safe. Thank you all.
Thank you. Thank you so much. Thank you, sir.
Thank you.
Thank you. Thank you.
Thank you.
Bye-bye.
Good night.
Good night. Good night, sir. Good day.
Hi, sir. Good night.
Good day. Good day. Good day, Professor.
Yeah. God bless you, Manoj.
Thank you, sir. Thank you. Thank you so much for caring to come today.
You.
Yeah.
No. God bless you. All the best.
Thank you, sir. Thank you, sir, for attending.
Right. God bless.
Good night. Good night.
Good night. Good night.
Good
All
night.
permission, we are ending the session. Thank you.
Bye. Thank you.